There we go, off and running.
Hello, everyone. This is Kathy Bush from DandleLION Medical, and thank you so much for all joining our webinar this morning that is titled NICU Music Therapy, and our faculty presenter is Maxwell Corrigan. Until last week, Max was the music therapist at Orlando Health Winnie Palmer Hospital for Women and Babies in Orlando, Florida. And we are happy to say that he just started a new job last week as the clinical research coordinator at Winnie Palmer. So congratulations to Max. In his previous role as a music therapist, Max provided music therapy interventions to address the physical, emotional, cognitive, and social needs of neonates and parents in both outpatient and inpatient settings. Primary music therapy goals in this setting included enhancing neurodevelopment, symptom management, and improving caregiver bonding. Max graduated with a Master of Science degree in Creative Arts Therapy, including graduate training in mental health counseling and music therapy. He's a board-certified music therapist and completed specialized advanced training in NICU music therapy through the National Institute for Infant and Child Medical Music Therapy. And as we mentioned, Max just began his new role as clinical research coordinator in the Winnie Palmer Hospital NICU, and he is currently the principal investigator for a NICU music therapy study. Welcome, Max, and thanks so much for sharing your information.
Thank you for the introduction. So yes, I'm Max. I work at Orlando Health Winnie Palmer Hospital in Orlando, Florida. I used to be the music therapist in the NICU, and I just recently moved to a new position. But something, a little bit of background on the NICU where I work is it's a very, very large NICU. So we have over 140 beds. We have pretty much every specialty you can imagine. So we do see a lot of different types of babies here. And today, what I want to do is just talk a little bit about what music therapy usually looks like in the NICU and across all those different populations as best I can in the short amount of time. Music therapy is such a broad field, and NICU music therapy, even though it's more specialized, is still a very broad field. So I'm going to do my best to go over a few different things and give you a good picture and overview of what that is. So my objectives for today, the things that I kind of want everyone to take away and maybe learn something new, is first, I just want to give a little bit of an overview of what music therapy is generally. That's something that is kind of plagued with some misconceptions sometimes, just the broader field in general. I want to touch a little bit on what makes NICU music therapy distinct and specialized within the broader field of music therapy. And then I want to touch on a concept called music medicine, which I'm going to talk about and kind of compare and contrast against music therapy practice. The second thing that I would like to do, which is going to be a bulk of what I talk about today, is how music therapy interventions work in the NICU, what they are, what are some protocols for music therapy interventions, and how overall there's a component of attention to family-centered care when it comes to NICU music therapy interventions. And then the last thing is I really hope you can come away with some ideas of how you can work with the music therapist in your unit or facility, especially if you work in a NICU, and hopefully give you some ideas of what you can do with your music therapist there, or maybe give you some ideas of potentially hiring one or thinking about what that might look like at your facility in the future. So off the bat, I just want to start a little bit with some background on what music therapy is. I'm just going to briefly go through this, but what I'd like to do is, if you see a little raise hand icon, I would like to see if anyone works with a music therapist currently. So if you see that raise hand icon, if you could just click that. Okay, so a few people, not everyone. Okay, so you can put your hands down. Let's see, who actually works in a NICU right now? All right, a lot of people. 52. Okay, about 50 of you. Okay. All right, so that's good to know. If you see the chat bar, what I'd like you to do next is just kind of type in a few words that come to mind when you think of the term music therapy. So you put your hands down, and in the chat bar, just write a few words. What comes to mind when you think of the word music therapy or the term music therapy? Okay, someone wrote my name, that's funny. Soothing, calming, okay, relaxation, coping, sensory regulation, neurodevelopment, okay, pain management. Okay. Okay, awesome. So what I noticed is a lot of people are putting down relaxation, comfort, calming, and that is one aspect, of course, of music therapy practice in general, especially in the NICU. So I would probably put that under the domain of maybe symptom management, possibly. Some other people had some ideas of sensory regulation or and state regulation, neurodevelopment, bonding a little bit. Okay. All right, so what I'm going to start off with here is just a broad definition of what is music therapy according to the American Music Therapy Association. So this is the big definition given by the big governing association in the United States that looks over all the music therapists that are board certified and practicing in the United States. So this definition here has a few big components to it. So one, that music therapy is a clinical and evidence-based practice. I'm going to go through some different literature today, some different research, and I hope that you can come away with a better idea of the rigor of music therapy practice according to the research that's out there. I'm going to talk a little bit about music interventions, especially specific ones, and then I'm going to talk about individualized goals. So a lot of people in the chat were really listing different goal areas: relaxation, comfort, regulation, bonding. And then I'm going to talk about how it's important for the music therapist to have a therapeutic relationship during their practice and in their sessions with their clients and their patients and the families. So those are the big components of what makes music therapy what it is. There's a research base for it. There are specific music interventions or protocols that have to do with music and the power of music to enact positive change on people. There's going to be individualized goals. So there's going to be really specific things that you're targeting. And then there's going to be some aspect of a relationship with the client, the patient, the family, because all of those things work together to really make music therapy work. And I just wanted to point those out in the definition. Just want to go through a few misconceptions. Music therapy is a profession, and I know that's kind of funny to say out loud, but sometimes you hear a lot, especially in some literature, you hear, well, the effects of music therapy on so-and-so, or people might say, well, music therapy has great effects on this and that. But what I want to really emphasize today is that there are specific interventions within the broader scope of music therapy that target specific populations, diagnoses, and different outcomes. So using music therapy, thinking of it more as a profession or a service rather than intervention is a really good way to go. Again, it's research-based. On the right side, I have it's not complementary to an alternative, and that's sort of an opinion of mine. I'll say that off the bat. But I think it makes a lot of sense, especially in the NICU, where you have so much research on some of these music therapy interventions that it really is important to make it a standard of care. And complementary and alternative means it's not really standard of care. It's either complementary with an already standard practice or it's alternative to that. And music therapy is neither. I would say it's a standard and a staple in many ways, and hopefully you'll get that impression after today. It's practiced at the bachelor's level, master's level, and doctorate levels. So all music therapists must have a university degree in music therapy, 1,200 hours of practica and internship experience, and then pass the board exam. And then in addition to that, there's several specializations. And today I'm going to talk about NICU. So next, what is NICU music therapy? NICU music therapy is a designation and sort of a sub-practice of music therapy. It's a specialized training, I guess you could say. And my specialized training comes from the National Institute for Infant and Child Medical Music Therapy, which is housed in Florida State University. So this is really the major training that music therapists get when they're in the NICU. And you have a little definition or kind of overview there. And it really emphasizes evidence-based practices of music interventions in the NICU with premature babies, babies that are in the NICU for other medical reasons, and families that are caring for those infants. And down below, you see that arrow. This is just kind of the progression or a little bit of overview of what that specialty training entails. So there's a clinical fieldwork component to it. There's a lecture series, and there's a couple of board exams that you have to take in order to call yourself a NICU music therapist. There's a great breadth of research related to NICU music therapy practice, and I'm going to go through some of those randomized control trials today and the meta-analyses that exist in the field. And then the clinical practice, there's some standardized and some protocolized music therapy interventions in the NICU that are specific to this sort of NICU music therapy training. And I'm going to kind of go over them a little bit. Music medicine. So music medicine is another term that you might hear in the hospital setting. And you might actually find that it's something that you already practice if perhaps you're a nurse or another healthcare professional that uses music day to day or with your patients in the NICU or otherwise. There's plenty of Cochrane reviews that look at music therapy practices for different populations, and I just pulled this quote out because a lot of the times these Cochrane reviews have to sift through a lot of literature that doesn't necessarily differentiate between music medicine and music therapy, and there's a really simple way to kind of determine, you know, which is which. And really, music medicine can be defined as a music intervention that's administered by a healthcare professional that is not a music therapist. So how do we determine that? Well, kind of bluntly, is there a music therapist involved? Usually if there is, the case is they're doing something that is a music therapy intervention that has a protocol, that has a good theory behind it, that there's some sort of therapeutic relationship involved. Also important, obviously, to look at the rigor of scientific evidence. Today I'm going to really talk about some strong literature in the field of NICU music therapy. And a lot of times we don't have as much literature specific to populations and diagnoses when it comes to music medicine practices. You know, things that come to mind are maybe putting music on a CD player or on a television that might be in a room or something. And then, are there specific and measurable and individualized clinical goals? So music therapists will all do evaluations and assessments. They have that procedure in place for their practice, for their standard of care. And then they're going to come up with broad goals and measurable things that they're going to track over time according to the type of therapy that they're providing. So that's a really big difference between some music medicine practices and music therapy, is that there are measurable and there are defined clinical outcomes that are really specific to protocols and the outcome that you're trying to get to. So these top two pictures that I have on this slide are sort of what I think of sometimes when I think of music medicine. I think of someone having headphones on while they're in the hospital, listening to something, and oftentimes the intention is to help with comfort or relaxation. And oftentimes you see music medicine practices as putting music on and then leaving the bedside and then coming back, seeing how it worked. On the bottom picture there, that's a heart player in a NICU unit, and I'm gonna guess and strongly guess that this is not a music therapy practice. One, because the heart player is sort of in a general area of the NICU unit. Music therapy practices are really individualized. And if you're in the middle of a unit and you're providing music or sound, you really can't see the responses of the baby or of the client that you're working with. And that's really important, especially when it comes to sound. Secondarily, having music in a large space like that, you really don't know how it's being saturated in the area, and maybe there's babies that just can't handle that sound right then, and especially if you're not there to see what they're doing, you can't decide if you're actually causing harm or not. So sometimes people who practice music in large spaces in different hospital units, NICUs included, usually with a harp, they might be considered music practitioners, which is a totally different designation and profession. So not to be confused with a music therapy practice. Okay, so what I'm going to do next is I'm going to go through just a few different NICU music therapy practices. I'm going to go through some different protocols. I'm going to talk about how they work generally, and I'm going to talk about the outcomes that they're usually meant for. And I'm just going to talk about some of the research that has been going on related to the interventions. So the very first one that I'm going to talk about today is called multimodal neurodevelopmental stimulation. And this is a very common intervention that NICU music therapists use with premature infants. And the idea is that infants who are born premature, they have a pretty low tolerance for different types of input in their environment. They're not used to having all this sound, all this touch, all these new sensations that they wouldn't otherwise be having. So what we want to do is we want to help them habituate to those sensations. We want to help them essentially get used to these sensations. And over time, this can happen, but this is just a way to sort of speed up that process. And it works from a theory of sort of classical conditioning, if you're familiar with that sort of psychological concept. So we want to desensitize them. We want to get them used to the sensations so they don't have as many startle responses, so that they don't have as many DSATs, they don't have as many episodes where they're clearly agitated and not tolerating the touch or the sound that might be necessary for their medical care. So the way this protocol works is there's a systematic use of auditory input, touch, and vestibular input that gets provided to the infant at levels of toleration. So generally starting off with some humming or singing, and then moving on to some different touch, usually touch hold sorts of movements on the head and the arm and the leg and back. And then kind of keeping an eye on the stress cues of the infant as you go through a progression. And when you get your stress cues, you stop, you give a break, and sometimes you terminate the session depending on what they're tolerating. And I know it sounds a little scary in the NICU when we use the word stimulation, but what's really great about this intervention is that when it's conducted properly by a music therapist, there is a continuous assessment of their toleration ability. So we want to make sure that they're getting some input, but we want to make sure also that we're not giving them too much that it's going to harm them. So what I have here on the bottom is just a great RCT that was conducted related to this protocol. So what they do is they enrolled 2 arms in this experiment, a total experimental group and a total control group. And then they use this multimodal neurodevelopmental stimulation protocol on these babies 32 to 36 weeks. So what they would do was provide this intervention for about 20 minutes or less daily until the infant was discharged. Keeping in mind that, you know, when they say daily in the study, they don't always mean daily. There are some days when the baby just can't handle it, or when the nurse maybe has said there's something going on and it's not going to be a good day. So that's part of the protocol too. You always want to consult with your other healthcare professionals in the hospital to make sure that it's a good day to do something. And all these infants too were under 2,500 grams at birth. So what you find here in this study was a really interesting outcome where the infants that were receiving this protocol, this music therapy protocol, were actually going home an average of almost 13 days sooner, 12.9 days sooner than the control babies. An interesting observation, if you look on the chart too, is that for those infants that were provided music with singing only, the males did much better when there was guitar added, which is part of the protocol too. If the baby can tolerate having some extra layer of auditory input through very softly strummed guitar, then that is implemented sometimes. And what you see is for the female group that had guitar and singing, they actually had a greater impact on their length of stay. So they went home much sooner. And this is something that really speaks to our understanding of neurodevelopment in general, where the male neonate brains are a little slower developing than the female ones, which means that the males are just not tolerating as much right away, and the females are tolerating a little bit more. So this sort of research is really important for us when we're doing these sorts of stimulation interventions with babies, just keeping an eye on, you know, the males are going to have a little harder time in general tolerating certain things. So we usually actually don't even use guitar with the males, especially, at least at first. And with the females, we know that we can kind of try that, and usually it goes a little bit better. Okay, moving on. The next part of the neurodevelopmental stimulation is making sure the parents are aware of what's going on and figuring out ways that they can be involved with providing some of this care. It's obviously very important for parents to feel close to their infants, to have some opportunities for bonding and for relationship building. And we want to make sure that if they're going to use touch and they're going to use sound and they're going to use singing, that they can do it in a way that's going to be helpful, and they can do it in a way that's going to be evidence-based. So what I have here is just a neurodevelopmental stimulation education. Essentially a protocol for teaching parents about the neurodevelopmental stimulation protocol that I just mentioned and went over, so that they can use it a little bit on their own to some degree, and then they can you know, find more ways to interact with their baby, even though the babies might be premature and it might be kind of scary to do some different things with them. So this study down here that I have is a really interesting RCT, looking at pretty much the same population as the last study, under 37 weeks and under 2,500 grams at birth. And what this study did was the music therapist actually met with the parent once for an hour session, and they taught them about the protocol, the neurodevelopmental stimulation. They taught them a little bit about stress cues. They taught them a little bit about how to use their voice in a calming and comforting way through a lullaby style of singing. And then they made sure they met all the criteria of understanding what was going on and how they could use their voice and touch for the benefit of the baby. And then they tracked a few things over time. And on this chart on the bottom here, it was a really interesting outcome they found, was that just that 1 hour of education had a great impact on how much time they spent in the NICU. So that was a very cool thing to see, was that those parents that received that hour of psychoeducation were actually spending way more time in the NICU than the parents that did not receive that education. Also in the experimental group where the parents got the education, those babies had a shorter length of stay and a greater average weight gain, which was another great outcome to see that kind of imitated the findings in other RCTs that have been done. Okay, so the third intervention that I'm going to talk about is the Pacifier activated lullaby system, the PAL or the PALs. So this is a very, very interesting intervention that has to do with a specific device, which is called PAL or the PALs. And what this device is I'm just going to go to the next slide to show you some pictures of it. It's set up as a speaker in a computer system and then hooked up to a pressure sensor, which a pacifier gets connected to. And how this intervention generally functions is it's a way to reinforce different sucking behaviors, non-nutritive sucking behaviors, via a music positive reinforcement. So what you have is a device with 2 speakers on it to play music binaurally, meaning equal access to both ears, which is important for neurodevelopment as well. And then depending on the amount of sucks that the baby gives or the pressure that they're sucking at, the music plays out of the speakers. And so the idea is the baby is being, it's an operant conditioning sort of procedure. So positive reinforcement. When you do a certain behavior, you get a certain reward. In this case, the reward is sung music. These devices come with a generic female sung lullaby system, but a lot of times, especially nowadays where we're seeing the importance of mother voice, these devices can be downloaded with recordings of the mother, which is used very often. And that's exactly what happened in this study here. So in this study from 2014, it was a really solid RCT looking at this system to help with different feeding outcomes in premature infants from 34 to 35 weeks. And in this study, what they would do is they would have babies who were in this age range who were taking less than half of their oral feed, and they were giving them 5 consecutive days of 15 minutes of this intervention. So they were going to the baby about 30 to 45 minutes before their scheduled feed. They were hooking up the pressure sensor to their pacifier, and then they were rewarding them for a certain number of suck bursts and pressure. What they also did, which was really great for the study, is they actually worked with the moms to get recordings of the moms singing 2 different lullabies for about 5 minutes, and then they would loop it for about 15 minutes and use that as the reward system. So the 5 consecutive days, 15 minutes a day with this system compared to just the standard routine care for infants who are working on oral feeds, nipple feeds. And what you had here was a lot of interesting, significant data controlling and looking at the PAL versus the control group. So you had a greater increase in their feeding rate in the experimental group. You had a greater increase in their oral volume intake, and you had a greater increase in their oral feeds per day. You also had in the study a greater ability to transition to full oral feed sooner, so 31 versus 38 days. So this was a very interesting study looking at a true experimental group versus a control group, looking at how the PAL can be implemented to help with different oral feed outcomes. So very cool. Here it is again. All right. This next intervention, you might have seen it before in different articles. It's an intervention that's often called contingent singing. So the idea of using music contingent on the baby's behaviors. So depending on what you're doing, you provide certain music, usually live. The idea is that if you can use music that is contingent on the baby's behavior, you can, again, condition them to have certain states. So help with relaxation states, help with self-regulation states, help with reducing irritability, improving sleep. And the idea is that you usually sit with the baby, maybe it's a full-term infant, maybe even it's a preterm infant at times, and you provide sung music in a lullaby style to their toleration, depending on what they're doing. So I'll give you an example of that. In this study down below, you have a very interesting study looking at full-term healthy babies. So this wasn't done in the NICU, but it was done with babies in the first 6 weeks of their life. So in this experiment, what they wanted to see is if contingent singing provided by a mother with music therapy guidance could help reduce crying time with infants who were having a lot of crying episodes. So what they did is they met with the moms of these infants in each group. In the experimental group, they taught them a little bit about how to sing in a soothing way. They helped them develop a special song. And then what they did is they said, you're going to provide this song when the baby is calm and not crying. You can do whatever you'd like with them while they're crying to help them calm down, but once they're calm and once they're not crying, you're going to do this song for them. You're going to do this special song for them. And in the control group, they were not directed to do a special song. And what they found was that crying time significantly reduced across the weeks for the babies who had the contingent singing from their moms as opposed to the control group. What was also very interesting was that on the 6th week, they brought all the moms in and they did sort of a play session with them. So what they did was they used an assessment tool called the Looking, Touching, Talking, Smiling Parent and Infant Interaction Coding Scale to look at the different sorts of behaviors, bonding behaviors, social behaviors that were going on between the mom and the child in each group. And the underlined values there are the ones that were significant at the 0.01 level, and the ones that are starter are significant at the 0.05 level. So in the experimental group, the babies that had this routine contingent singing were actually looking more at their moms. They were having more babbling. The moms were singing, and there was a greater increase in infant response in general. Okay, so moving on. I'm going to talk a little bit about an idea of music-based play. So music-based play is an idea of using music and music instruments to promote different developmental skills, especially related to fine and gross motor and even auditory developmental skills, social skills, and even language skills, communication skills. And the study that I'm going to highlight here was a study done just last year, looking at older infants who were admitted in a NICU. So like I said earlier, I work in a very big NICU. So we have infants sometimes that are here until even a year of life sometimes. We have a specific unit even designated for babies with lots of complex medical things going on, where they might be here for a very long time while we work with them on different respiratory goals, feeding goals, neural related goals. So they can be here for a while. And it's really important to not forget about the developmental needs of these babies and the developmental milestones that we need to get them to. So oftentimes, music-based play is a way to address some of those things to make sure that there's no, or at least reducing some of the delay when it comes to these developmental outcomes. So in this study, they looked at different sort of regimens for providing music-based play for these sorts of infants that are in the NICU long term. So what they did is they came up with 2 sorts of regimens, each 4 weeks long. In one group, they did this music-based play intervention twice a week, and then in the other group, they did it 4 times a week, and then off 1 week, 4 times a week, and then off 1 week. And the intervention protocol was fairly simple and straightforward. It was a hello song, so introducing the baby with some hello, beginning social skills related to greetings, doing some finger play, doing some vowel songs, so encouraging cooing and babbling and consonant sounds, doing some instrument play at midline, so providing some opportunities to do some auditory localization, so finding where the sound is in relation to their body, doing some introduction to some controlled novel stimulus, so introducing them to some sounds that maybe they wouldn't otherwise be introduced to if they weren't admitted, doing some animal sounds and animal songs, doing some shaker play with some hand over hand, really gentle hand over hand assistance, doing some movement songs, encouraging some more midline play, body awareness, a little bit more introduction to some different vestibular stimulation, and then a goodbye song. And what they found was that in both groups, there was a great increase in their gross and fine motor skills, their cognitive emotional skills, and their communication domains. And they used a developmental assessment called the DAISY-2, the Developmental Assessment of Young Children in the 2nd edition, to kind of track these things and monitor them. What was really interesting was that there was similar increases in these domains for both groups. So even though one group had the more intense therapy once a week and then off, and then once a week and then off, they had about equal improvements, and they were both quite large improvements over this 4-week period. They also found that that if there was parents involved and there was parents learning about this process of music-based play and how to use music to interact with these babies, then the outcomes were actually better, which is something that kind of we intuitively think about. All right. So what I'm going to just touch on really briefly is a little bit of the review of meta-analyses in this population and related to some of the protocols that I discussed. So I feel like I'm talking really fast getting through these, but really the reality is those are just a few interventions in the NICU. Those are just a few protocolized interventions in the NICU related to NICU music therapy, and there are many more that music therapists do on a daily basis. I just don't have the time to go into them. I'm going to touch on a few other concepts in a little bit, but I'm not going to be able to go into that depth that I did with the other ones and talk about as many of the RCTs. But I just wanted to touch on this slide here just because it's important to know that while I did mention just a few RCTs, there's been analyses related to these interventions that are pretty robust, and it gives us a good idea of how well these interventions work and how well we can generalize them, because one RCT is great, but 30 RCTs or 14 RCTs is even better if we see consistency. And we in fact do see consistency in these meta-analyses. We see that mother singing, sometimes recorded music, and heartbeat sounds can have a great impact on different physiological aspects of the baby. And I'm going to touch on some current research related to this a little bit later, because I didn't really touch on a protocol for recorded mother singing in the earlier slides. Also found that neurodevelopmental stimulation has great effects on length of stay across several studies, and the PAL treatment has a great impact on sucking and feeding ability across many studies as well. A more recent meta-analysis, again, found that maternal singing and live caregiver singing and contingent singing, sort of like what I was talking about, had a great effect on physiological outcomes as well, like respiratory rate, and helped to decrease behavioral distress in general. Also, an interesting finding looking at different studies that measure the anxiety of mothers, which is really important when we think about postpartum depression and how important it is to keep that in mind when we're doing interventions with caregivers. So the inclusion of moms in these different music therapy interventions has a pattern of decreasing their anxiety, state anxiety, and trait anxiety, sorry. So some sort of guidelines, recommendations that we can take away from these larger reviews and these RCTs that I looked at, because people always ask me, they say, well, what age can we do this at? What weight can we do this at? What diagnosis can we do this at? And it's important to note that, you know, I wish there was a great cookie cutter approach to some of this stuff, but the reality is that music therapists need a lot of training and they need a lot of background knowledge, because they're taking in not only what the literature says, but they're taking in their own experience with these babies and families. They're taking in, you know, what they've done in the past and what the patients are doing in the moment and what their values and preferences are. So while we can generally say sort of what, you know, populations work well for these interventions, there's always new innovations that are happening, and there's always stuff going on in the moment that we need to really keep an eye on and really be aware of. And that's why a music therapist involvement is so important, because music therapists are trained therapists. They know how to look at all aspects of the care, and they're not just going to provide an intervention just because a baby is a certain weight or certain age. They're really going to look at a lot of things. But in general, what we find in terms of outcomes from some of these babies is that 28 to 36 weeks and under 2,500 grams is a great way to start when you're looking at neurodevelopmental stimulation. That 34 to 35 week range for the PALS is another great thing to keep in mind when you're looking at that intervention, sort of that time in the baby's life where really they're getting to a developmental neurological level where they're starting to process input into their learning and their memory right at that 34, 35, 36 week range, and where they're starting to learn how to nipple feed a little bit. Volume and loudness. I did not even touch on this yet. That I could do a whole hour on sound and noise in the NICU. But what we do know is that there's obviously the AAP guidelines for 45 A-weighted decibels in the NICU, which is so important. That's always something to keep in mind. I had mentioned earlier that it's important not to totally get rid of sound or stimulation for certain ages of babies in the NICU, because we want to get them habituated a little bit. We want to get them used to it just a little bit. And what we find in these studies is that most people, most music therapists, are using music at the loudness of about 65 to 75 C-weighted decibels. So that's different than A-weighted. They're not the same loudness. That 65 to 75 would actually probably be like more around like 60 A-weighted decibels, maybe even a little less. And C-weighted is used more for music because it really captures all the different frequencies. There's a lot of frequencies going on for different types of music, especially if you're using guitars and voice and music instruments and things. But it's also really important that when you're using music and sound at a level a little louder than maybe the baseline in the room, that you're always keeping an eye on the baby's responses. Again, that evidence-based practice sort of model, you need to keep in mind what the baby's doing and what the responses you're getting are. So when I see things like having recorded music in an infant's room or a harp player in a general area, my first question is, how are we monitoring the baby's responses in real time? Because that is really, really important when we're talking about decibel levels especially. Another thing to keep in mind for a NICU-MT recommendations is that caregiver voice, especially the mom's voice, is so important. And we're seeing more and more research where having a mother's voice around, because it's so familiar and because it's so rewarding and so soothing, can have great effects on different outcomes. Music-based play sessions should really be a standard part of a lot of long-term NICU facilities. Just having that 20 to 30 minute, 2 to 4 times a week sessions for those babies at that full-term age can really make a great impact on their developmental milestones. And last, contingent singing. So I talked a little bit about full-term infants who had some inconsolable crying episodes, but when we translate that into the NICU environment, I think of contingent singing for the neonatal abstinence syndrome population, using music as a way, contingent music as a way to help promote self-regulation skills, increase sleep, comfort. Even some babies with some severe neuroirritability, I found in my experience that contingent singing and teaching contingent singing to parents can really reduce those events. There's also some current research looking at the PAL system for neonatal abstinence syndrome, finding ways to reinforce non-nutritive sucking behaviors for these babies because of the endorphin release of sucking and the soothing effects that has, and just the effects of recorded music in general for this population, especially if it's the mother's voice, can be really, really important and really impactful. Okay, so a little bit about some upcoming research, upcoming practices. For a lot of music therapists, you might say, well, this is already standard care for me. I already do these things. But for a lot of the medical community, this really is upcoming. So with new technology and new devices, there's always changes in practices. And one of the most fascinating things that I'm seeing is this concept of heartbeat recordings. So a lot more people are looking at ways to record not only mother heartbeat sounds, but infant heartbeat sounds. And then using different types of speaker systems that can be managed in a safe and soft and not too loud way are another important technological advancement that are small enough that can fit in a patient room. But touching on the heartbeat recording, one of the things that is happening at a really steady rate is music therapists using heartbeat recordings as legacy building projects. So for those babies that are in the end of life stage, finding ways to help parents connect with them, to bond with them, to do something in that part of their life that is meaningful and impactful and help build a legacy can be really important. So heartbeat recordings is a really interesting way to do that by recording an infant's heartbeat, and by allowing the parent to be a part of that process can be a really great way to build a memory with their baby and to keep that memory on something close to them, like their phone or their computer or in their car. Sometimes I've even had parents that want to choose music to pair with the heartbeat. And this is sort of where a lot of the creativity comes into play for music therapy practice, is finding a way to have a heartbeat be sort of the sounding board or the backtrack or the main beat for a certain song that might be meaningful or impactful for a family, and just giving that extra significance of the memory making legacy building project. Also, heartbeat recordings are sometimes even used in NICUs to give parents a bit more sense of connection to their baby, especially if they're not in the hospital a lot, or if there's siblings involved, kind of coming up with ways to give the siblings something to identify and to think about as far as their sibling goes. And there's also some procedural support applications, which I'm going to talk about next. So right now, I'm an investigator in a study in our NICU looking at recorded maternal voice and maternal heartbeat sounds as a way to help babies calm down after the retinopathy of prematurity eye exams. So what we're doing in our study is we're recording mother voices and mother heartbeat sounds. We're coaching them on how to sing in a lullaby style. We're helping them record their voice in a way that's soothing and slow enough. And then we're editing that together into about a 5-minute clip. And we're providing it for infants after the retinopathy of prematurity eye exam. So if you don't know about an ROP eye exam, it can be quite painful for babies, and it can really be difficult for them to make it back to baseline, especially throughout the entire day. So what we wanted to really look at was if this intervention could be used in a way to help babies return to baseline quicker than standard care. So our subjects are 31 to 36 weeks. They're under 2,500 grams. They're in an open crib. They're not intubated. They don't have any other sort of analgesic medication or anxiolytic medication, and they're scheduled to have an ROP exam. We're looking at pain through the premature infant pain profile, and we're looking at pain at baseline, during the eye exam, 1 minute after the eye exam, and 5 minutes after the eye exam. Keeping in mind we're providing the recording of the maternal voice and the heartbeats right after the eye exam. We're also looking at some other peripheral outcomes like length of the eye exam, parent involvement, age, gender, ethnicity, kind of seeing if those things will have an impact on the pain scores. And these are some of our preliminary results right now. We've collected data for about 83 babies. We video record all the sessions, so we actually have data for 94 babies out of 100. But not all the videos have been reviewed yet. And what you see here is that for the baseline and the eye exam, the pain scores are pretty much the same. So that's a good testament to the reliability of our measuring system. But then what you have is the really good data when you get to post 1 and post 2. So 1 minute and 5 minutes after the eye exam. In an experimental group, you see a little quicker progression to that baseline. By 5 minutes, they're already at baseline, as opposed to the control group where they're still trying to get there. And a 1-point difference in the PIP score can be the difference between an apneic event or a tachycardic event. And it's really important that we avoid those things, of course. So getting back to baseline as quickly as possible is really important. And what we're finding in this study is that it's exactly what's happening with this intervention of mother voice and mother heartbeat sounds. So that's some exciting stuff, and hopefully we'll be done with that in the next few months and maybe have something published in the fall or next year. All right, what I want to talk a little bit about next, just for the very last part of this webinar, is some collaboration. So I really wanted to mention that current research for a few reasons. One, because it highlights some new technology and some different ways that we can incorporate recorded music and music therapy practice into a standard of care that really needs help. That is the soothing and comforting of babies after specific procedures, but also because it's a great opportunity to collaborate with nurses. Because I can see an intervention like that being used in the future with nurses. That is, the music therapist meets with the parents. They work on educating them on use of auditory stimulation, or maybe even other sorts of stimulation for comfort and relaxation and interaction. And then coming up with a way to record their voice, coming up with a regimen for that recording, and then working with the nurses to have that music and have that recording available for infants at different periods during the day, whether it's after a procedure or a time when the baby's awake or fussy, as a way to help them calm down. So I think that's a great opportunity for music therapists and nurses to collaborate, especially considering that I feel like a lot of NICU nurses are already interested in using recorded music in their practice. There's a lot of nurses that I work with that are very eager to use music with their babies. But what I would always ask, and what I would always recommend, is working with your music therapist, even if you think some of the recording music you're using is benign, because there's always different ways to do it, and there are some great evidence-based ways to provide recorded music that can be really even more impactful for the baby. I often collaborate with the rehab specialist, especially in our complex care unit with those babies that are here a long time. I talked about music-based play interventions. That's a great opportunity for rehab therapists and music therapists to combine forces, to combine expertise, and really work on all those different milestone domains. Getting on the floor, if possible, on a mat, the babies are able to get out, using different sorts of instruments and different sorts of movements, different sorts of songs and consonant sounds, and finding a way for music therapists to really be a part of that rehab team and work towards those developmental outcomes is so important. Also feeding, OTs and SLPs being so involved with baby nipple feeding in the NICU, music therapists could be a great ally for them when it comes to some of those other interventions that I talked about related to feeding, but also ways to help calm babies and help babies regulate so that they're not as disorganized during some of those feeds. Also collaboration with chaplains. I think this is a really important one. I think there is a lot of great opportunities to create important traditional meaning out of NICU experiences, whether that be providing music for certain ceremonies or events that are going on, finding ways to work with patient preferences on coming up with a way to make the ceremony more impactful or more meaningful, and working a little bit more on just those general coping skills for caregivers is really important as well. I think end of life, music at end of life, oftentimes called thanatological work, can be really important. I've definitely been involved with parents who I worked with, and we'd come up with plans for withdrawal of babies where they wanted certain music, live music in the room during the withdrawal, and that was something that we could do. We could come up with a playlist together. I would bring my guitar, bring my songs, be there as an extra support for the family, and provide that sound to kind of fill that environment in a way that the parents preferred and really wanted it to be at that end of life stage. So I think there's a lot of great opportunity there. Also work very closely on the palliative care team to come up with ways to meet the preferences of families at all points in the patient's infant's journey during the hospital stay, whether or not that's end of life or just generally during the course to work on different symptom management outcomes or even bonding outcomes. So who should collaborate with NICU music therapists? Well, I would say everyone. Whether that's the rehab specialist, where you're working on those developmental milestones or feeding perhaps, or you're working with nurses coming up with ways to do recorded music regimens or coming up with schedules of when music therapy would actually be appropriate during the day, depending on the baby's responses and what they have going on, or whether it's the parent or the baby themselves, helping to educate parents on different ways they can interact and use auditory input with their babies as a way to help with comfort or developmental outcomes, and as a way to just make the environment a little less scary and help with different coping skills when it comes to the premature and sick infant. So I really think that music therapy deserves to be a staple in NICU care. I think there's plenty of research to show its benefit. I just think a lot of people aren't aware of that research. I also think that NICU music therapy contributes wholeheartedly to family-centered care. I think that is integrated into every single intervention, whether or not it's having the parent involved or having the parent educated. And then I also think that NICU music therapy is really conducive to collaboration with a lot of different professionals. I only mentioned a few today, but there are many opportunities, and that's something to get creative with at your facility. So something to keep in mind, evidence-based practice is a process. I would love to give just really precise, this is what you do for this case, but as we know, it really takes a few things. You need to have the best evidence available, but you need to also have in the back of your mind your clinical experience and expertise, and also the patient responses and preferences and values. Music therapy is multifunctional. There are many different outcomes that music therapists address. I only mentioned a few today, but music therapists also work in school systems. They also work in pediatric hospitals and adult hospitals and forensic settings and private practices. And there's just a really deep community of music therapists across the country that work in a lot of different places. What's really great is that there is some specialized training for music therapists who have an interest in NICU, or who have an interest in special needs schools, or have an interest in rehab, or have an interest in hospice or palliative care. And that's something to keep in mind, and to ask around if you have a music therapist that you're working with, to ask them kind of what kind of specialized training they come from, or what was their internship like. Evidence is important. Music therapy is a research-based profession. I think that's one of the reasons why it's so important to have it in the NICU, because we know in a lot of ways it works. There's always more research to be done, and I think with advancements in technology, there's always more innovations to be done in music therapy as well. And safety requires knowledge and training. I talked a little bit about sound in the NICU. I talked a little bit about touch in the NICU. I talked a little bit about parent education. And I just want to reassure that music therapists are really focused on the safety and well-being of patients at the forefront. We are very familiar with decibel level recommendations. We're very familiar with stress cues and patient responses. If we work in a NICU or a medical setting, we are very familiar with the different diagnoses and populations, and we can make a good clinical judgment on a lot of those patients. And we're also know that we need to consult with medical professionals and rehab specialists when there's something that we don't know or something that we need help with. And I think that's another important reason why collaboration is necessary, not only because we need the help of others, but because sometimes rehab specialists and nurses and physicians need the help of music therapists to figure out how to incorporate sound in a healthy way, how to do noise studies in their NICU, how to utilize parents in bonding and interaction with their babies or with their siblings. And this is the last slide. It's just a little bit of resources to kind of move forward with your education on NICU music therapy. A few books there that I think are really great. That guidelines book, the second one, has a great chapter on music therapy with the preterm population and full-term infant population. Musictherapy.org is the website of the American Music Therapy Association, so I would definitely check that out. It has a lot of good information. And this last article is really targeted towards nurses. So it's got some guidelines about how nurses have a role in the neuroprotection of infants when using music in the NICU. So I know I talked really fast today. I got through a lot of different slides. I know it was kind of dense, but what I want to do is just thank everyone for coming. I really hope that you learned something related to music therapy in general and also specific NICU music therapy practice. And I'm really glad you came, and I'm happy to take any questions at this time. And I'm going to leave up my references slide just for those people that want to kind of know where I'm getting my resources.
Oh, Max, awesome. That was such a really, like you said, dense, but just really thorough and wonderful review of the importance of music therapy. So thank you so much. And for those of you, there's been several places in the chat area where you can download Max's slides and you'll get to have these references available to you. So now we do want to open it up to questions, and I can see we have many already waiting. Kathy Randall is going to help me field the questions, but if you do have one, if you could hover over the bottom of your Zoom screen, you'll see a little tab that says Q&A, and if you want to write your questions there, Kathy will read them, and Max can do his best to answer as many as we can.
Yeah, these questions have been really great, so I've been trying to kind of go through them. One question came up that I thought was interesting, and that was, are there any negative effects of music therapy on babies in the NICU?
I would say there's definitely negative effects of an intervention being done without proper training and understanding of the protocol. Just like lots of interventions, whether they're rehab or medical or psychological, if they're not done properly with care, then yeah, there can be harm. And that's one of the reasons why we need specialized training in NICU and in music therapy in general, is because you need to have a good knowledge of how the things that you're doing and how you're using music to affect positive change, but also seeing what the harm could be if an untrained professional was doing those things. So I think that with anything that has a great potential for good, if it's not done properly, yes, there can be some damage and harm if it's not done the right way.
Thank you. Is my mic better?
Yes.
Okay, thanks. I just unplugged and replugged. Gosh, I'm really struggling. There are so many good ones. One of the questions that came really early was, how do you coach the families on songs to sing and which songs to sing and the pacing? I know you mentioned that as part of one of your interventions. This person was commenting, I think it's Katie Martin was saying that some of the families don't know a lot of songs. So how do you coach people through that?
That last article that I referenced in the previous slide is a really good one to look at, and it's a reference that music therapists use too. What we found in a lot of our preliminary research is that there's certain qualities of music that are least alerting to babies, and those are the guidelines that we use based on the preliminary research that were non-clinical. So we're not looking at clinical outcomes, we're just looking at what qualities of music are going to be best for our interventions. So some examples of those things would be music in 3/4 meter. Again, these are music terminology, so I'm not sure how much of that you would know, but 3/4 meter lullabies. Decibel levels is of course one of those things. Speed and pace. Melody contour, so using music that doesn't have a lot of jumps. So a lot of lullabies will stay within a certain range and not jump around from really high notes to really low notes. Also chord structure, so in music we have different chords in harmony, and keeping it very simple, 2 to 3 chords and in a major harmony. Again, music terminology is a little tricky. Part of the training of music therapists is, of course, understanding music theory and musicality. So it would be hard to explain some of those things if you're not familiar with with music in general, but there are guidelines related to chord structures and melody and tempo and pace and loudness that you would go over with the family and help them understand and demo those things with them. If they have songs in mind that they know, then that's a great place to start. And also we have whole lists of songs that we can bring that fit all the criteria that I just explained, and even teach some of them. We're very culture focused too, so a lot of times I've worked with parents who have traditional songs in their own language that they know, and just helping them come up with a way to adapt them in a way that's not going to be very alluring to the baby can be really important. Again, importance of having a music therapist do some of those things is because we have some experience with different cultural music as well, and cultural backgrounds as part of our competency.
That's great. I think that dovetails nicely with another question that said that sometimes nurses want to play music that's their choice, not necessarily the family's choice or necessarily having the qualities you just said. So this person was saying they've been working for 3 years to make a playlist, and that they're finding it to be really difficult to get staff engagement and practice change when they've been trying to eliminate the nurse's preference in the songs. And have you encountered this as a challenge in your practice? And do you have any suggestions? She's saying she doesn't have a music therapist. They've had a consultation, some long distance consultations with some music therapists, but just any ideas you have around some of this situation?
Yeah, so definitely, yeah. I would say that there are many times when people want to implement a music medicine practice in their facility, and there can be some great that comes from recorded music if someone has a general good intuition about what might be comforting or calming. I would only say that with the expertise of the music therapist, you might actually get a much better outcome. So that's one way to approach it, is to say, what you're doing is great, and I love where you're going and where your head's at, but let's try some of this music that I have as a way to make the outcome even better. Sometimes that's a great way to introduce other concepts and other sort of peripheral aims of the music therapy practice. So while the nurse is really maybe focused on the symptom management and the comfort of the baby, you can say, well, look, maybe we should use some music that has voice in it, and maybe only a single instrument, because this is a vital period of time when they need a lot of exposure to language too. And if you're only playing instrumental music, we're not getting those outcomes. Or why don't we try doing some recordings of the mom's voice? It might help her feel closer to the baby. And also, I've read a lot of papers that show that mom's voice is really helpful for comfort and relaxation of babies also. So maybe we can try that. So I would go approach it from that angle, and it's always going to be a challenge because music is so familiar to people. It's part of people's life, and everyone, a lot of people really want to use. I'm hearing an echo.
Yeah, me too.
Yeah, me too.
Where that came from. I'll see if I can suss it out. Try again, Max.
Okay. How's this?
Yeah, it looks like it maybe went away.
Okay.
Sorry, so you were right, that really distracted right in the middle of that end of that question. So I'll move on to another one. There's so much background noise in the NICU. How do you work around that, or do you incorporate that into your therapy sessions?
Yeah, background noise is really important to be aware of whenever you're implementing anything new into the soundscape, which is the noise or sound environment in a particular space. So when I talk about decibel levels, especially intervention decibel levels, I'm talking about decibel levels where the baseline is already really low. So if you're providing a decibel level of a certain amount in an intervention, you're not going to provide it unless the environment is already soft. So that's another aspect, another part of music therapy practice that I didn't even go into today, which is monitoring of soundscapes, especially in the NICU, where those regulations are particular. So again, in that last article that I mentioned, that Detmer article, he talks a little bit about implementing recorded music, but making sure to monitor the baseline first. So we want to make sure that we're getting as close to that AAP guideline as possible. But to my knowledge, that is really, really hard, and not a lot of people do a great job of that. So sometimes it's very hard to get in there as a music therapist when the environment is already so loud. We don't want to add more sound to the environment of the baby if it's going to be a decibel level that is too much. So I would say there's a lot of opportunity for music therapists to do different noise studies in the NICU, work with your nursing scientists, work with your audiologists and your rehab specialists, and really get in there and see how we can create more of a culture of silence and quietness in your NICU. And I think music therapists can be a big part of that, because we can't do our intervention if it's already so loud. And really, a lot of people shouldn't be doing their interventions if there's any sort of sound component and the environment is already too loud. You're just going to add to the noise, and that's not good.
Well said. Yes, definitely. Interesting question here. Is there a specific tool that you use to determine the response to music, or do you just look at the infant's kind of overall state cues and their vital sign stability or changes or modulation in that? Or what do you find in the studies that you presented, or just in your own practice?
Sure. So some of these studies actually had surveys specific to music responses, but related to adults, sort of the parents' kind of perception of the music experiences. For infants especially, we obviously can't ask them and survey them those things. But I think maybe what the question is getting at a little bit is that we need to control and see if it's actually the music intervention doing the change and not something else. And I think that's a methodological question. A lot of these studies that I showed you today were very well controlled and very well designed, which means that in some cases they were even blinded to the people doing the outcome measures, so they didn't even know if they were getting music or not. So music therapy is really the use of music interventions to look at non-musical goals. A lot of people will say that in music therapy, and that makes a lot of sense in NICU music therapy, because we're looking at non-musical outcomes like physiological responses. In the developmental stages, we're looking at head turning sometimes, we're looking at finger grasping at times. We are looking at behavioral states of distress, squinting or facial movement that's indicative of pain or distress. So apart from the design itself, a lot of us are using standard tools of measurement, especially in research, to look at these outcomes. I was using the premature infant pain profile, which is a very valid and reliable tool in the NICU to look at procedural pain and post-op pain. So these are common tools, some of the nursing tools even that nurses would use to measure these things. And then just through our design, we're just making sure that it's the intervention as best we know and not something different.
Awesome. I think this also plays into another question, which you just kind of, you hit on a little bit, which is really watching the infant's cues to the music. And so should music then be used as a structured treatment with an observer so that the music can be, reduced, or the stimulation be reduced if the infant is negatively responding, versus just a filler, a space filler, like putting on just a country music DVD or CD in between cares? So could you comment to that individualized bit about the care versus just kind of adding a stimulus to the environment?
That's one of the biggest things that differentiates music therapy from other practices of music in hospitals, is that we have a consistent monitoring of patient responses in the moment, because it's usually a live process, or we're there the whole time when we're doing the music, if it's recorded too. So I would say that, yeah, absolutely, it's important to monitor the responses of a premature infant or even a full-term infant in the hospital, or even an infant that's healthy and full-term at your house. You know, it's really important, especially for them, you know, so we can monitor hearing loss, first of all. But in the NICU, especially when those infants are just learning to tolerate stimulation, and maybe there's other things going on if they're older, like they're having surgeries or they're having other sorts of medications, or they're working on feeds and they're having some distress in their bowels or something. Yeah, it's very important that we're keeping an eye on their responses to the music. For recorded music, that can be pretty tough if you're just putting it on or leaving, but there are guidelines to that. And that's that last article that I really put up there, which is really focused towards nursing care and nursing use of music, because you don't want to have music on forever, like all day. You want to have breaks from it. You want to do it at times when the infant is awake and not while they're sleeping. You want to make sure that you're keeping an eye on their responses so that if they're not tolerating it, you turn it off and then you reassess, and maybe you go talk to your music therapist and see what else you could do to help, or if there's anything else that could be done music-wise to help.
Great. And then there's a couple questions just about kind of general, maybe technology. First is, do you have to be a music therapist to use the heart rate recorder? Is there a specific name of that product?
I don't know if I should get into product names here, but using those digital stethoscopes are really designed for physicians and nurses and respiratory therapists who are hard of hearing. We've just been adapting them to record heartbeats, so those are used by a lot of different practices. We're not using them for diagnosing anything or anything like that. We're just using them to record and use as a playback intervention, either for the infant or the parents. I would say that for people who are not music therapists, who are thinking about using heartbeat recordings as more of a legacy building or memory making intervention, or doing something like having those things available at the bedside, I would really consult with the people who do that intervention for a living, because there's a lot that goes into them, especially the legacy building and the memory making. Some people might think, well, I'll just do it, it'll be a nice thing for them to have. But you need to assess the cultural preferences of the families. I've had families who say, no, I'm not gonna capture the soul of my baby. You know, it's really important to be very delicate when you're introducing these things, and really assessing the cultural preferences, but also understanding that the intervention is not just recording a heartbeat and giving it to a family. There's a lot that goes into the bonding process and the memory making process, and finding ways to make it an experience and a service, and not just something that you check off your list and you put aside and feel good because you did it and you think they'd like it. So I would really make sure that you look into the greater, broader intervention itself and service itself, and consult with those people that do it very often, because there's a lot that can be overlooked, and that's something to keep in the back of your mind, I think.
That's great. Can you just reinforce the ages that you recommend starting, gestational ages, for music therapy? I think you had a slide kind of at your end there with the recommendations.
Yeah, well, it depends on the age we're talking, or the intervention we're talking about, and the diagnosis in the population. So that is a question I get all the time, and I would refer almost all the way back to the beginning of my slide when I talk about music therapy as a service and not an intervention. So when you say, well, what age for music therapy, I would say, well, it's not an age for music therapy, it's an age for a music therapy intervention. So for example, the neurodevelopmental stimulation intervention, I would say we're looking usually on average more like that 32-week postmenstrual age range, but sometimes a little earlier at 28 weeks. And then for the PALS intervention, you're not going to have babies starting to nipple feed maybe until 34 weeks anyways, and more likely around 35. So that's when you would get them involved in that, but only if they're really having a lot of trouble with the feeding, and there's other assessments to take place too to see if they can tolerate something like that, and if there's any other contraindications. So it's a whole process, and it's a whole service and there's specific interventions that work better for specific ages. And sometimes those things can even change depending on the, what's going on for the baby that day, or the cultural preferences, or the family values, or what you've experienced in the past, and if there's a surgery going on or something, there's always something going on. So it's really important to think about the intervention in terms of the age, and not music therapy as just one thing that covers all ages and populations.
Got it. Well, I think we've covered the majority of them. There's a few more questions in here I wish we had all day. And it sounds like people, either want to contact you with more questions later, or hire you and they want you all over the country to be in 100 places. So I think everyone's really impressed by just the thoroughness of this presentation, the evidence base that you've provided, and then just some of the exciting ways that we can each incorporate some of these ideas, and really respecting the music as the therapy, and it's not just an addition to the the daily noise of the NICU, and having a real intentional purpose, and needing to be really guided by someone who has really this specific training. So I just want to say thank you so much for all of that. And I don't know, Kathy Bush, if you have any final wrap up comments or questions.
Well, I do. We need to talk about your CEs. So in order to receive your free CE, you will need to fill out the webinar evaluation. In the chat area, Kathy will be posting the evaluation link. If you're watching the recording, please go back to the email you received with the link to the recording and click on the link to the evaluation form. You will receive an email with a PDF of your CE certificate within 24 hours after you fill out the evaluation. Be sure to check your spam if you don't get it in that time period. If you're watching live and don't have time to fill it out right now, or your hospital has blocked access, you will receive an email within a day or so with a link to the evaluation, as well as a link to the recording. Now, if you're viewing as a group, and I think several of you are doing that, you need to each log on to the evaluation form in order to get the CE. Now, we at Dandelion hope that you'll like us on Facebook or LinkedIn to be the first to find out about what's new at Dandelion. We have 2 exciting new products coming out in the next few months. The first one is the Crown Cradle that will launch next month. And the Crown Cradle will help you to support the baby's natural head shape. It's a very exciting product. We can't make claims about it, but it's well researched and patented, and you won't want to miss the launch information about that product. We also hope you will visit the Dandelion Medical website for our next webinar, which will be coming up at the end of April. And it also has links to the recordings of our previous 3 years of webinars that are all still active and available for continuing education credits. So again, Max, you were absolutely stupendous. Thank you so much for being our faculty presenter today, and for all of you that are online listening, either to the recording or live. Thanks so much for your participation and your amazing questions, and we hope to see you again in April. So have a great day. Thanks, Max.